Welcome to myeyacademy.com. I'm Professor Mahfouz Hussain from Jinnah Medical College, Pakistan. It's a platform for ophthalmic teaching for everyone. In this video, VHB Chapter 10, Section 5, we are going to discuss miscellaneous glaucomas. In the miscellaneous glaucomas are those glaucomas which cannot directly fit into the open angle or close angle glaucomas, and we will describe them separately. The glaucomas that we have included in this talk are congenital glaucomas, lens-induced glaucomas, neovascular glaucoma, and absolute glaucoma. Congenital glaucoma is a separate entity, while the lens-induced and neovascular glaucoma, they can induce glaucoma by different mechanisms, so we have discussed them separately, and the absolute glaucoma is the end stage of all the glaucomas. First of all, we will discuss the congenital glaucomas. Congenital glaucoma is defined as increased intraocular pressure with no associated eye anomaly. Eye is perfectly normal otherwise, and there is usually some maldevelopment of the anterior chamber angle which causes increased intraocular pressure. It's usually bilateral, and males are affected more than the females. Congenital glaucoma can be divided into three forms. If the IOP is increased before or at birth, we call it true congenital glaucoma. If the IOP increases between the birth and 3 years of age, we call it infantile glaucoma. And if the IOP increases between 3 and 16 years of age, we call it juvenile glaucoma. So congenital glaucoma can be true congenital, infantile, or juvenile. Symptoms of the glaucoma are ophthalmos, which means enlarged eyeball, cloudy cornea because of the increased pressure in the anterior chamber, and lacrimation and photophobia so severe that the child cannot open the eyes. The signs are increased intraocular pressure, hazy and edematous cornea due to endothelial damage, and large corneal diameter because of the increased pressure, usually more than 12 mm of mercury. The treatment is, medical treatment is usually not enough and sufficient, so we move on to surgery. In the surgery, we can do goniotomy, which is incision in the anterior chamber angle to open it, or trabeculotomy, which is the excision of the trabecular meshwork, or the trabeculectomy as we do in other types of glaucoma. Then in the miscellaneous glaucoma is the lens-induced glaucomas. Lens-induced glaucoma can be in different ways. The phacolytic glaucoma is because of the lens, which is hypermature. So hypermature cataract releases proteins, and these proteins block the trabecular meshwork and produce a secondary open-angle glaucoma. Now the lens can cause a glaucoma in a different way called phacomorphic glaucoma. In the phacomorphic glaucoma, mature cataract swells up and blocks the pupil. The pupil block results in secondary angle closure glaucoma. And the third type of lens-induced glaucoma is called phacopupil block glaucoma, which is a dislocated lens physically blocks the pupil and produces the angle closure glaucoma. So the lens can cause secondary open angle glaucoma, and it can also cause secondary angle closure glaucoma. Then the third variety we're going to discuss is the neovascular glaucoma. Causes of neovascular glaucoma, you should remember: central retinal vein occlusion, branch retinal vein occlusion, Eales disease, central retinal artery occlusion, and diabetic retinopathy. All these can cause ischemia of the retina. And the pathogenesis: hypoxic retina because of the ischemia produces angiogenic factors, mainly VEGF. This VEGF induces retinal and anterior segment new vessels. Now the mechanism of the glaucoma is more than one types. Neovascular glaucoma can be secondary open angle glaucoma. This happens when initially the new vessels block an open angle. Later on, A membrane contracts and closes the angle completely, so the glaucoma converts into secondary angle closure glaucoma. So it starts as an open angle and then ends up as a closed angle glaucoma. That's why it's described separately. The treatment is treat the cause. Anti-VEGFs are given into the vitreous cavity to stop the process of neovascularization. Organ laser photocoagulation is done for the same purpose. Then you can do the topical medical treatment like we do in other types of glaucoma. Then you switch on to trabeculectomy and the cyclodestruction, which means destroying the ciliary body so that the production of the aqueous is less than what it is, to reduce the pressure in the eye. And finally, the absolute glaucoma. Absolute glaucoma is not a separate glaucoma. It is end stage of all open and closed angle glaucoma. So if you cannot control or treat the glaucoma, eventually it ends up into a blind eye, and we call it absolute glaucoma. It's more commonly seen after neovascular and inflammatory glaucomas, but can happen because of any glaucoma. Because of persistent elevated pressure, the eye becomes hard, blind, and painful, and we call it absolute glaucoma. So absolute glaucoma is not a separate entity. Any glaucoma can end up as an absolute glaucoma. Symptoms are hard and painful eye, no vision, usually NPL, which means no projection of light, NPL, no projection of light, fixed dilated pupil because of the ischemia, and secondary glaucomatous optic disc atrophy. The treatment is you treat the cause like anti-VEGFs for the new vessels, medical treatment to reduce the pressure and make the eye comfortable. If that doesn't work, then the surgery, and we usually end up in cyclodestruction, which means the cryotherapy or laser therapy to destroy the part of the ciliary body so the pressure goes down. Thank you very much for being with me, and please do give your feedback. Thank you.